primary polydipsia and diabetes insipidus.
In clinical practice, a patient presenting with excessive thirst and large volumes of dilute urine immediately raises the differential of primary polydipsia versus diabetes insipidus. While the symptoms overlap, the underlying pathophysiology is completely different. In this session, we'll break down how central and nephrogenic diabetes insipidus differ from primary polydipsia, how the diagnostic approach, particularly the water deprivation test and ADH administration, helps distinguish them, and why recognizing the difference matters for both exam questions and real-world patient care. Okay, so let's start with USMLE style case vignette. A 25-year-old man presents with a 3-month history of excessive thirst and urination. He reports drinking over 10 liters of water daily and waking multiple times at night to urinate. Laboratory studies show low urine osmolality despite a high serum osmolality. His serum sodium is slightly elevated. After water deprivation, his urine remains dilute, but responds to Desmopressin administration with increased urine concentration. What is the most likely diagnosis, and how does it differ from primary polydipsia? This patient's presentation is classic for central diabetes insipidus. His inability to concentrate urine despite dehydration, followed by a positive response to desmopressin, indicates deficient secretion of antidiuretic hormone, ADH. In contrast, primary polydipsia results from excessive water intake suppressing ADH release, leading to dilute urine but generally normal ADH function. Nephrogenic diabetes insipidus, on the other hand, involves renal resistance to ADH, so urine concentration does not improve with desmopressin. Understanding these differences is key for exam success and effective patient management. Primary polydipsia and diabetes insipidus are both characterized by the production of large amounts of dilute urine, often accompanied by excessive thirst. Let's break down the key differences between primary polydipsia, central diabetes insipidus, and nephrogenic diabetes insipidus. Primary polydipsia is caused by excessive water intake. This is often due to psychiatric conditions or lesions affecting the thirst center in the brain. As a result of the high fluid intake, the serum osmolality drops, and the body's antidiuretic hormone, or ADH, decreases or remains normal because the body naturally suppresses it. Central diabetes insipidus, on the other hand, is the result of decreased ADH release from the posterior pituitary gland. This can happen due to idiopathic causes or as a result of brain injury. Because ADH is low, patients lose large amounts of free water, leading to an increase in serum osmolality. Nephrogenic diabetes insipidus is different because the kidneys are resistant to the effects of ADH. This resistance is often hereditary or caused by certain drugs such as lithium or dimeclocycline. In these patients, the ADH level in the blood is normal or even elevated, but the kidneys still don't respond, so serum osmolality remains high. Let's talk about what happens in the water deprivation test. In primary polydipsia, when water is withheld, urine osmolality increases significantly, usually above 700 milliosmoles per kilogram, because the kidneys are still able to concentrate urine correctly. But in both forms of diabetes insipidus, there is no change or only a minimal increase in urine osmolality after water deprivation. This is because, without ADH or with unresponsive kidneys, the body simply can't concentrate the urine. Finally, let's see what happens after giving desmopressin, which is a synthetic form of ADH. In central diabetes insipidus, there is a marked increase in urine osmolality, more than 50%, because the kidneys are responsive once the missing hormone is replaced. In nephrogenic diabetes insipidus, however, there is minimal or no change in urine osmolality because the kidneys cannot respond to ADH, whether it's natural or synthetic. In primary polydipsia, desmopressin isn't usually necessary. For primary polydipsia, treatment focuses on fluid restriction and managing any underlying psychiatric illness. Behavioral therapy can help reduce compulsive water drinking. In central diabetes insipidus, the key treatment is desmopressin, a synthetic ADH analog that replaces deficient hormone and reduces urine output. For nephrogenic diabetes insipidus, treatment targets the underlying cause, such as stopping offending drugs like lithium. Additionally, low-salt diet and thiazide diuretics are used to decrease urine volume. NSAIDs may also be helpful,